It's lovely to see you all, and it's always really nice to be able to come and present the research that I've been involved in for a very long time. And my interest in this area of work all started off when I was a student midwife on my very first community placement. And what happened was we went out to visit a mum and her new baby, and the baby was dry. And so the midwife said, just put a little bit of olive oil on that. It's natural, so it's safe. Anything you've got in the cupboard, doesn't matter which type it is, just put it on. And I went away thinking, crumbs, you'd use that for cooking chips or vegetables, and you're putting it on a brand new baby's skin. Is that right? And I've always been a bit of a why person, so I suppose that was the start to this long career pathway that I've been on, doing research into skincare. So I'm going to share a bit of evidence with you. The programme of work at Manchester University in baby skincare has been going on since around 2008, 2009, and I got involved in 2012. And I've told you the reason why my interest was sparked, but we do know there's been a school of thought that perhaps what midwives and other health professionals recommend to parents to use on the baby's skin might have a connection with the development of childhood atopic eczema. We know that in the 1940s the prevalence of eczema was about 5% of school-aged children, and it's now approaching 20 to 30%. Depending on when it's measured. And in that time, our genetic predisposition has not changed. We're still made up in the same way. What has changed is the environmental factors. And one of those factors could be the use of certain products on the skin. So that's where my interest lays. I'm not saying that could be the only reason for a connection with the rise in eczema, but this is the one I've been looking at. So just before I start, I'd just like to highlight to you the bit of the skin that we're talking about. And we're talking about skin barrier function. So atopic eczema, the characteristic with regard to skin barrier function is a defective one. And that's where the barrier is not working properly. So water can be lost through the skin, and external irritants and allergens can penetrate the skin. And that all happens in the stratum corneum, which, if my hand stops shaking, is just that little bit there. So it's the very uppermost surface of the skin, the bit that you can touch and see, often called the horny layer. And you can also see on this diagram, because I might refer to it later, some skin cells there being lost through the surface of the skin. And that is absolutely normal, and you wouldn't be able to see that. You can on the diagram, but ordinarily that would be invisible to the naked eye. And that's an absolutely normal process called desquamation. Making it a little bit more clearer how the skin barrier works, you can think of the skin barrier in terms of a brick wall. So if you've got a really solid brick wall where the skin cells are the bricks, and they're all held in perfect alignment with the mortar, and that's the lipid lamellae part of the skin. So you can see here you've got a really strong brick wall there. It's absolutely solid, and that means that no water can be lost through the surface of the skin, and external irritants and allergens cannot penetrate, they bounce off. You can see some loose skin cells here, but if you think about the previous picture, that's the normal process of desquamation. That would be absolutely fine. What you've got here on the other side of the screen is a defective skin barrier, and that's where the skin cells have all started to shift. And the reason for that is the lipid lamellae have become less ordered or more fluid, and that's like the mortar in a brick wall crumbling, and you get cracks or fissures in the skin, and that means that water can be lost. So TUL is transepidermal water loss. So it can be lost through the surface of the skin, and external irritants and allergens can penetrate the skin, causing a more systemic issue. So that's what you'd see in eczema, and that would be characterised by very dry, cracked, red, possibly inflamed skin. So as midwives and potentially other health professionals, we tend to base our guidance on NICE guidelines when we're giving information to parents. The NICE guidelines for postnatal care are dated 2015, as you can see, that's the most recent update. There's only one reference to skincare in those guidelines, and as you can see, it says that parents should be advised that cleansing agents should not be added to the baby's bath water, nor should lotions or medicated wipes be used, and the only cleansing agent suggested where it is needed is a mild non-perfume soap. You might be interested to know, you might know already, and I apologise if you do, but for those of you that don't, when NICE update their guidelines, they don't update all the guidelines or all the guidance within that guideline, yet the date of publication will be updated. This particular guidance note in the NICE guidelines has not been updated since 2006 when the original guidelines were produced. So this guideline is completely out of date, and in fact since 2006 there's been a plethora of research into neonatal skin care that actually makes that advice harmful. So for instance, where it says suggesting a soap, we know that soaps contain sodium lauryl sulfate, which has been proven to be dangerous for skin. It's damaging to skin, so you should never recommend a soap. Where it says that you shouldn't put cleansing agents in the bath water, there has been evidence to show that that there are products that are not harmful to baby skin. They are as good as water for baby skin. So it means that parents can be offered a choice. We shouldn't just be promoting water alone. There is a range of products out there that have been tested as safe and they could be recommended. Same with wipes. There are some wipes as well that have been shown to be as good as cotton wool and water. So recently, I've been involved in quite a bit of skincare research. My PhD, which I normally speak about, is on oils. So if you have any specific question about oils, I can answer those separately because that's the research that I've led. But recently we've been commissioned by the Royal College of Midwives to look at some work with regards to promoting new guidance to health professionals. So it came in two phases. The first phase was a systematic review of the evidence and an audit of current practice. And the second phase was a mixed methods research study, looking at what content is required for new guidance, what format it would be best served in so that professionals took notice of it, and how best to disseminate it. So I'm going to give you a quick overview of that work that we've been doing. So the first phase was a collaboration between ourselves and the University of Leeds. The first thing that we did was a UK audit of heads of midwifery. So as you can see there are 189 heads of midwifery. And we sent them an online survey of almost 50 questions. So if any heads of midwifery are here, I really appreciate the fact that you filled it in, because that's an awful lot to ask of you. It was informed by a previous survey that we'd done, and that was good because we could see impact on research and how much had been disseminated and whether there'd been any change of practice. But it was open for 3 months. And I'm only going to give you a few bits and pieces from that. First of all, just to say there was a 45% response rate, and you might think that's really low, but it was an online survey, and we know that the average for an online survey is about 30%. So we did exceed that, so we were quite pleased with the 45% there. And the conclusions of the audit were that very few hospitals actually had a policy for neonatal skin care, so they didn't have any on-hand guidance for their health professionals to be able to look at to give the most evidence-based information to parents. And funnily enough, the majority of those that did have policies were actually district general hospitals. Only one large teaching hospital had a skincare policy, and you'd think that was, arguably quite strange, because they're the ones who tend to be the most research-intensive hospitals, but only one of them had a skincare policy. We found out that little information is given about skincare to parents for one reason or another, and particularly about baby massage, and that's not surprising because there is no research that looks at skin integrity with regards to baby massage practice. We found out that tradition and personal experience does inform the information that health professionals give to parents. Few units reported stocking or recommending products, and we concluded with the fact that we needed more education on the evidence for health professionals. We then conducted a systematic review, which we follow Cochrane principles, so that's what that slide is showing you, and I won't go into that, but it means that we did it in a robust way. And we looked at 5 aspects of normal baby skin care for babies between 0 and 6 months, because you normally get a diagnosis of eczema between 4 and 6 months at the earliest, so that's the reason why we took it to 6 months. We looked at bathing and cleansing, nappy care, care of the hair and scalp, management of dry skin, and baby massage. For hair and scalp care and baby massage, there was no evidence to look at for a systematic review. And you know that there is evidence out there with regards to baby massage, but it never looks at skin integrity. It only looks at things like neurodevelopment, growth, weight gain, reducing crying, reducing colic, and bonding and attachment and that type of thing. And obviously my interest is in the skin barrier, so there was no evidence that's looking at the skin barrier. This is a very busy slide, but what I'm trying to get across to you is that there's a lot of evidence out there for baby skin care, but the problem is when you do a systematic review, what you hope is that there's a lot of evidence and that you can pool all that data to get a really, really strong answer, because your measure has so many more participants involved, because you can pool all of these studies together, you can get a much more confident answer to what you're trying to find out. The problem was, with the studies with skincare, hardly any of the studies had the same outcome measures. So they used different body sites, they used different time points to measure the measurements that they were doing, and they used different tools to measure the different outcomes. So that meant that we couldn't pool them. They were all had to be kept separate, and we could only report on them narratively. So there was only one comparison that had more than 3 studies where we could pool data, and that was the J&J Baby top to toe wash against water alone. So I can show you a few results there for the meta-analysis that we were able to do on that. All of the others, the one at the bottom there did have 2 studies that looked at pH neutral soap versus water, but not 3, and you need 3 really to get a decent meta-analysis, at least 3. So we weren't able to pool those. With regards to nappy care, there was only 1 outcome that was repeated in 2 different studies. Again, we need at least 3 to do a meta-analysis. And then, although there were quite a few studies that looked at emollient versus no treatment when looking at dry skin, again, there was only 6 outcomes that were repeated in 2 studies. So again, we couldn't do a meta-analysis and just had to report on the data. So this is the meta-analysis for that one comparison that I told you about at the beginning. And I don't know if, like me, when I first came into this, I was quite frightened by statistics. So I'll try and explain this in the most easy way I can. But basically, the most interesting thing about this is your confidence interval. And the confidence interval is usually the figures shown in brackets. And you think of 0 being where the line of no difference is. And if a confidence interval crosses the line of no difference, it means there's no difference between the 2 groups in the outcomes. There's no significant difference. And you can see here that all of these confidence intervals go from a negative to a positive. So therefore, they all cross 0. So that means there was no difference found in the things that we were looking at in those studies between the group using the product and the group using water alone. And you might think, okay, well so what? There was no difference found, so I can ignore that. But in fact, it goes completely against the way we give information as midwives, because definitely the majority of midwives give the evidence cotton, wool and water only. And this is showing that that's not correct. Parents do have a choice. They could use this product or water. So you should be presenting the evidence to them and giving them that choice to make themselves, so they can make that choice rather than us deciding for them that they should just be using water. This is just another way of showing that information. So this is a forest plot here, and you can see the line of no difference drawn vertically from the 0. And you can see the confidence intervals are the horizontal lines, and they cross that line of no difference. So it's just again showing you that there's no difference between the groups. And the big black diamond is the pooled result, and that also crosses the line of no difference, just to prove again that there's no significant difference between the groups. So the conclusions of the systematic review, obviously it was a lot bigger than that. I haven't got enough time to go into that completely, but it has been published in Midwifery, so you can always go and have a look at that if you would like to and have the full range of results. But basically we found out that the studies were all of variable quality, all reporting different things, different time points, different measurement tools, different outcomes, well, body sites. The other thing was sometimes they didn't report all the data, so we'd have to go back to the authors, but then they couldn't give us the data, they couldn't provide us with that. So that it made it very difficult to get all the information we needed. But the evidence from the most robust studies showed that for bathing and cleansing in particular, you could now offer parents a choice. You didn't have to say cotton wool and water alone. The oils section in the management of dry skin showed that olive oil and sunflower oil should definitely not be recommended for management or treatment of baby dry skin. They've both been proven to impede the development of the skin barrier from birth, so you shouldn't recommend those oils. In that study, the observed study, the no oil group had the best skin, so you should just tell them the dry skin will just resolve itself. They don't need to treat it. And then obviously our clinical guidelines do not reflect our current evidence base. So recommendations for practice were that healthcare professionals should promote evidence-based choice. So give all the information to the parents, let them make their own decision and not feel guilty about using a product that's potentially been shown to be safe. That clinical guidelines and local policy should reflect the current evidence, that there should be education and training for healthcare professionals and students, because we know from the audit that this is not the information that's being given and that they don't really know what the current evidence is because the NICE guidelines are out of date, that there should be regular audits of practice to make sure practice is changing, And we need more robust trials, really, to look at this, to make sure we can get a bigger pooled result in any systematic reviews. So the second phase of the work, which I introduced at the beginning, was a much more, it's a larger team, because what we wanted to involve was health visitors, neonatal nurses, dermatology nurses, parents. So there were lots of different people involved in this one. And we wanted to determine the content for new guidance, the format, and the best way of disseminating it to multiple audiences. So the first thing that we did was a survey of lead midwives for education, because we thought, well, the first place we need to get in is the undergraduate education providers. So this had a really good response rate, because I told you the average was about 30% for online surveys, and we got over 70% for this one. But they're a captive audience, so it was really quite easy to get hold of them through the LME network. We found out that only 6% of higher education institutions don't provide skincare content, so therefore 94% do. And then we found out that their content was underpinned, in the majority of cases, they said by research and guidelines, but 15% admitted to underpinning the content by tradition and personal experience. We then did a national survey of parents, which we tried to advertise through all social media networks. Incredibly difficult to get parents to access a survey like this, but it's not really one of those hot topics that they really want to, it's not a buzz topic, so I can understand it. We did get nearly 2,000 views of the survey, so 2,000 people clicked on it, but the first page did say you need to have had a baby in the last 12 months. So if I look at it in a positive way, I'm trying to think, well, maybe they realised their baby was older than that, so they didn't fill it in. But if they clicked on it and then thought, I can't be bothered with this, and then didn't fill it in, that's a little bit more negative, but that could be another reason for them not filling it in. We got 111 responses, but we had to eliminate some of those because they were ineligible, and we ended up with 96. It had a good mix of ethnicity, and that sort of reflects the population. The interesting thing was we asked them had their baby had an allergy diagnosis of atopic eczema, and 23% said yes, so that does fall in line with that 20 to 30% prevalence, which was good to see. A very busy slide, but I'll just point out to you that loads of parents admit to using products from birth on their baby. So that most of the cases, they've admitted to that. Most of them say that the main influence is their friends and family, not health professionals. Another interesting thing you can see there is for management of dry skin, 20% are using olive oil. And we know that olive oil is dangerous. It's proven in every single population, mice, adults and babies, olive oil is damaging to the skin and should never be recommended for the skin. Funnily enough, we got almost 20% coconut oil there, and we do know from other research that we've done in this phase is that health professionals think, well, if I can't recommend olive and sunflower oil, I'll just recommend something else. So they've moved on to rapeseed oil or coconut oil, but they haven't been tested either, so I'd just be very wary of recommending any oil for the skin. And again, for massage, the commercial baby oil there is the highest, but again, no robust large randomised control trials for those either. So we then did a qualitative study, focus groups, 4 focus groups and 23 semi-structured telephone interviews with participants from Manchester and London to try and see if the North and South agreed, and they did, and a mix of people that we spoke to, so doctors, neonatal nurses, massage instructors, health visitors, midwives, students, lead midwives for education and parents. There's lots of data for that, and I'm currently in the process of writing this up, but the overall theme was the need for clear and consistent advice, and this particular student summed up, if you're midwives, you'll know you fall into one of these 3 categories. So she said, there's basically the midwives who've heard the research and are interested in the research and actually ask the students and say like, oh, you're from such and such institution, you have this conversation with the parents because you know the latest research. Then you get the midwives who just haven't heard the research and just aren't really aware of anything, and they just carry on going on doing exactly what they've done for 30 years or whatever. And then you've got the midwives who've heard the research and they're just plain old ignoring it and saying, I've been qualified for 40 years or whatever, and I've done it this way ever since, and I'm not changing my practice. And this is the reason why we find it so difficult to change practice in skincare. It's a really, really ingrained traditional practice to recommend oils for dry skin, this misconception that natural is safe, but it's not. Natural oils contain things that are perhaps potentially harmful to the skin. This thing that will natural as water, so recommend water alone, and they don't really know the evidence. So I just thought she summed it up quite nicely. We also had a stakeholder group running through the research from beginning to end, and they met at the beginning, middle and end of the research, and that was really, really interesting, and it was really good to talk to them because you know, it was doctors, it was GPs, it was dermatology nurses, it was health visitors, it was massage instructors, it was neonatal nurses. It wasn't just our perception as midwives, because our core team at Manchester is midwives, and so it was really good to see their perception of skincare practice and skincare information provision, and have them informing the study all the way along. It was a really positive way of doing research involving them. So the main study findings were that there was a lack of awareness of what is normal skin and what actually requires treating, of the available evidence, of the influence to parents of having products displayed on hospital wards. That came up in this research. And there was a complete lack of awareness of NMC code 6.1, which I'd please encourage you, if you don't remember anything from what I've said, go and have a look at that, relating to brand discussions versus evidence provision. It was obvious that conflicting advice was being given to parents. The clinical guidelines need updating. Again, that comes through all the time. And where there's no evidence, there was an overwhelming consensus that they prefer an expert opinion rather than nothing. So the key messages today from my talk are to provide clear and consistent advice, and that's not only in the midwifery profession, but across professions, in any profession that's involved in childhood skincare. Do not recommend oils for baby skin. Remove any visible products from hospital patient areas, because as one mum said, parents are given an awful lot of samples of things, and I suppose, you know, if you give them things whilst you're in the hospital, your idea is that the hospital is endorsing this product. Advocate evidence-based choice, so give them the evidence, let them make the choice. And familiarise yourself with NMC code 6.1, which says to make sure that any information or advice given is evidence-based, including information relating to using any healthcare products or services. I think this issue, there was a massive theme that came through the research with this conflict that health professionals feel between talking about brands and perhaps thinking they're violating the code by recommending a brand versus providing the evidence. And that came up. But you are allowed to present the evidence to parents. So it might be that a brand is tested in the evidence, but you should give them that evidence and let them make the decision on what care they're going to give to the baby. It's their baby. We can't tell them one thing when there is evidence to suggest that there is a choice, because parents do feel guilty about having those products and they are using them. So by you saying cotton wool and water, that there was a theme that came through of this feeling of they were doing something wrong. So our next steps are we're meeting with stakeholders from all the professional bodies to try and get this guidance produced and then disseminated across all the different professions that I've told you about, and to parents as well. And that's hopefully going to involve some standardised question and answer sets for, particularly for midwives, because they're there right from the start. So instead of feeling some discomfort about how you present the evidence to parents and feeling as though you're in conflict, it'll give you a standard answer to give to parents, which hopefully would be easier. So that's coming in September. We're meeting with all the stakeholders, all the professional bodies. For you, please question your practice. Ask why. Don't just go along with the flow. And please spread the word about what you've heard. Thank you.